Welcome, everyone. It is 1:15 and time for our next presentation. Thank you so much for having us here with you at IHA's conference this afternoon. My name is Carolyn Catilli. I will be one of the presenters today for our topic, our title, Health Literacy Professional Development, Integrating Patient Experience and Application-Based Learning. I am joined with my colleagues Haley Fuller, Robert Goodman, and Denise Lamar, who will be introducing themselves as we move through the program. We come from Penn Medicine, which is a growing footprint. We go from South Central Pennsylvania, Southeastern Pennsylvania into South Jersey and Central Jersey. We are made up of facilities that we own and facilities that we have alliances with and affiliations. Our focus is on patient care. We're the home of the nation's first hospital. We are also the home of the first medical school in the United States. We have over $1.1 billion in research funding, and we have 900 plus service initiatives by our care grants. So community service is very important to us. You already have the objectives for the program, but this is what we hope to accomplish by the end of our time together. As I said, my name is Carolyn Catilli. I'm a patient education specialist. I am based at the Hospital of the University of Pennsylvania as part of Penn Medicine. I have been with Penn Medicine for the last 39 years. My PhD is focused in nursing, and I focused on geriatric health literacy. I've had numerous publications and have presented nationally and internationally. I'm also been past president of the Healthcare Education Association and also the co-author of the HCA, the same organization as Patient Education Guidelines. So it's a pleasure to be with you this afternoon. So we're going to be talking about this program that we offer that helps to enhance our staff's patient professional development when it's related to patient education. We have been offering this class, Teach Back, Helping Your Patients Understand, over the last 10 plus years, minus a year that we've lost in COVID. We originally focused on a shorter class that did the Teach Back technique only. However, staff commented they wanted to expand to all aspects of patient education, so the class expanded. We update the curriculum on a regular basis based on evidence-based practice, participant feedback, new technology services in the pandemic. And during the pandemic, we actually moved to virtual. We were all in person prior to that. And now we offer a combination of virtual and in person. And the virtual has given us the opportunity to open it up to our whole entire health system that we can all engage in one class together. And for those who do want the in-person experience, we do offer that in downtown Philadelphia at this point, although we have gone to different locations of our entities. So we use multiple teaching strategies in this class. We have the didactic section. In the didactic section, we'll incorporate video with patient examples, and we'll also incorporate role play. So our agenda basically looks like we start the morning at 8 o'clock. We ask the participants to introduce themselves. One question we ask them is, what do you hope to get out of this class? So we are able to adjust during the day based upon the feedback they give us for that, of what they are looking for. Most times we don't have to adjust much of anything because what they're looking for is the curriculum and the practice that they are desiring. And then from there, we move into talking about, and I'm going to cover the topics, but then we go into the didactic. After that, we have a session where there's a patient panel where they tell their stories to us about positive and maybe less positive patient education experiences. And then the afternoon, we run simulations with standardized patients. So here's, I wanted you to have a sample of what our curriculum looked like, because I hope that you're attending this because you'd like to see, is this something you could do in your organization? So we do a health literacy overview, really emphasize that 9 out of 10 people do not have proficient health literacy, and that comes from the National Assessment of Adult Literacy. We talk briefly about measuring health literacy, but not really a focus on that. We talk about culture and health literacy, cultural brokers, cultural humility, health disparities, health inequities. I've also started working with our planning committee and looking at marketing principles. I think it's really important to look at other fields that can enhance patient education and health literacy. And one of those fields is marketing. So we do talk about some marketing principles. We also talk about empathy development, and we do some exercises that help with empathy development. We direct them to our toolbox. We have a toolbox with Penn Medicine, and we've developed that toolbox by pulling from the Health Literacy Universal Precautions Toolkit. We also have, I had mentioned the HCEA Patient Education Guidelines. We pull from there, and also from Teachback, information from the Teachback field. We also have an emphasis on patient-centered communication. We talk about shared decision-making and motivational interviewing. So what I wanted to do at this point is just highlight to you some of the slides that we used during the presentation so you get a feel for the curriculum. After I do that, Bob is going to talk about his role on the patient panel and what he does with that and how he goes about doing it. At that point, Denise Lamara, who's the head of our standardized patient program, is going to talk about our standardized patient program. And from there, we're going to do a demonstration of how the simulation works in the afternoon. And then Haley Fuller, who's going to be the facilitator during the simulation, is going to end our program or pull it towards the end, talking about how she creates a very comfortable learning environment as the facilitator. We'll talk about some of our outcomes, wrap it up, and then at that point, we'll answer any questions that you have. So please feel free to post your questions in Q&A or in the chat. I know sometimes we ask for it in Q&A and it ends up in the chat. We will try to track both of them. And we'll get started here going through and looking at what some of our curriculum looks like. We have a tendency to talk about the 4 domains of health literacy to get people to think very broadly about health literacy and everything that impacts everyone's health literacy. So talk about fundamental literacy, science, civic, and cultural literacy. We also talk about conceptual models. Once again, getting everybody to think about what influences a patient's health literacy and where can we make a difference? And how does that tie into what they're doing in the class today? So we do talk about the causal pathways linking health literacy to health outcomes by Pak, Orlow, and Wolf. We showed the AMA video. Some of you may be very familiar with this video, Health Literacy and Patient Safety, help patients understand. It was done by the American Medical Association AMA Foundation. Excellent video. It is getting a little bit dated. I know a lot of us have talked about we need to find the time and resources to be able to update it. But in the meantime, it really is an excellent overview of health literacy and strategies to meet patients' health literacy demands. We also, to talk about culture and health literacy, we share the one article by Voyer, Rael, LaBerge, and Purnell that talks about the cultural differences of way older minority women looked at medications, adherence, and all that. So we discussed that article. And then we also discussed the book, The Spirit Catches You When You Fall Down, done by Ann Fadiman in 1997. An excellent example of how culture impacts health literacy. To help with empathy development, we go through this exercise. We explain to the participants that this is instructions they need to clean something. And so they need to read it, and then we'll have questions and everything about it. And so we ask them, can you answer this question? How you clean a capstan? Why are you having trouble answering this question? And get them to know what it feels like to step into an environment where you don't understand what's going on. You may not understand the language. You may not understand the jargon. And if you figured out that this is written backwards, till you try to get all the way through it, you've forgotten what the first sentence says. So that's one of the ways that we develop empathy. I had to post this slide because this is one of my all-time favorite slides. And to me, this just kind of wraps up what the American population looks like. Your green poles are all gone. Do you want to take a blue and a yellow? Usually we get a chuckle from the audience, but it really gets people to think about where is the American population? Once again, only 1 out of 10 people have proficient health literacy. That means 9 out of 10 do not. And we need to really think about that as healthcare professionals. So we get them to think about, you can't really do a good job of teaching until you understand where your patient's coming from. So we use this slide to really enforce that point. How do you get to know this patient? So we use this slide to get them to think about what are all the different questions you can ask? How do you approach getting to know the patient? This is the marketing part that I talked about. The book Made to Stick, excellent book, highly recommend. I actually recommend to the participants to read. And they basically looked at ideas that stuck, and here are the concepts that go along with ideas that stick. So we asked our participants to think about, do you do a simple message? Unexpected could be a little bit harder to build into it, but we actually show a Delta Airlines safety video where they add humor to it, the unexpected to it, like they show a camel smoking a cigarette and the flight attendant says, you got to put that out. So we demonstrate how you do something like that, clear ideas from a credible source, make it emotional, funny, sad, and tie it into a story. So we get staff to think about how do they make those marketing concepts work. Here are the patient education practice guidelines that I talked about from HCEA. We do go over the guidelines because they are the most recently published in 2021 that walks through evidence-based practice related to patient education, health literacy. We give them a case study, something for them to think about how, if you were writing this patient education or even telling this patient education, how would you do it? And so I asked them what grade level, so I want them to understand the concept of simple. So I asked them what grade level they think it is. I get a lot of 5th, 6th, 8th, maybe a 12th. And then I show them this is college sophomore and that the reading age is 39 and it should be 100 or closer to 100, I should say. And so that gives them an example of what simple is like. And then I asked them, okay, we've made it more simple. What grade level do you think this is? And they put that in the chat or they shout it out if they're in the room. And we say, yes, we got this down to the 8th grade level. And then this is from the American College of Surgeons. It's now out of print. I was very sad when it went out of print. I still cry every 3rd day at this point. And we walk through this and I ask them, what makes this excellent patient education? And they point out, the pictures, the simple words, the short sentences, the concrete ideas, basically everything that we learned from the marketing book. And I do the same thing with these 2 pages from the guide. And once again, the emphasis here is live well with diabetes, very motivating. You can do it, that type checklist, that type of thing, the use of white space. So we use this to really help them understand how excellent patient education is applied. We talk about teach back. We talk about the 3 steps, knowledge, attitude, and behavior, and give an example of a patient with Lasix. We give them other phrases. So we really emphasize that teach back shouldn't be testing the patient, but it should be getting the patient to encourage them to want to discuss what they've learned. And so we give them example phrases. We talk about motivational interviewing. Right before we go into we kind of combine a teach back motivational interviewing section together because motivational interviewing really goes for like open-ended questions. It goes for affirmations. It supports reflective listening. It supports summarizing. So these are some of the skills we want them to incorporate. And then we developed this a number of years ago, about 8 years ago at this point at Penn Medicine, where we want to have something marketing wise for our staff to think about how do you do evidence-based patient education? And we came up with Reach to Teach. So you relate to the patient and family, find out where they're coming from, what's on their mind, what are they worried about? From there, you make a plan to educate simply. And, from doing that exercise with guessing the grade level stuff, they begin to understand that, simple it's got to be really simple. We ask and answer questions, which means patient education is a conversation, not just a talk at you. And then we check for understanding, which is teach back, but check for understanding, reach, work better with Reach. And all this promotes health literacy. So we encourage our staff to reach to teach. And this becomes the framework for the class and the simulations that we do in the afternoon. From this point, we move on to some role playing. So they role play with each other and we have them do the Reach to Teach, but with something very simple, how to make peanut butter and jelly, grilled cheese, how to clip coupons. And we kind of wrap it up at that point and we move into the patient panel because now they get a chance to see things from the patient panel perspective. So at this point, I'm going to have Bob take over and introduce himself.
Hi, good afternoon, or good morning, I should say, everyone. My name is Bob Goodman. I've been a patient advisor at the Patient and Family Advisory Council at the Hospital University of Pennsylvania for about 8.5 years. And my transplant, heart transplant, was 9.5 years ago at also the Hospital University of Pennsylvania. My professional and career background, I should say, is all in the healthcare industry. I've been a hospital CEO, and I've worked a lot on the business side of healthcare for a long time. Certainly never, ever expecting to to ever have a heart transplant or anything like that. So I have a pretty robust 360 view of the world here. So that's who I am. So I talk a little bit about what our role is. Well, patients, we're storytellers, or we can be, and we tell our stories about great patient care, as well as our education experiences. We also tell stories that sometimes are not so great, but those can act as teaching moments for staff essentially at any level. We also try to provide perspective and context for things. We talk about policies and practices that can be improved, and that's the sort of thing that we do on the Patient and Family Advisory Council. And we also praise certain behaviors that we've experienced, whether it's on an inpatient basis or outpatient basis, and we hope that others will follow those kinds of examples. Next slide, please. We view the role as we look to add value to our own experiences, and as a patient, many of us really like to participate in care decisions. Not everybody does, but many of us do, and those that don't usually and hopefully have someone else that they can designate to do it for them if they can. When I was going through transplant, and especially the educational side of it, my wife was there at every moment, especially again on the educational side. There was so much to learn. It's such a shock in lifestyle and everything else, but so caregivers are wonderful people as it relates to this. And patient care is not just something that's done in the hospital. It's definitely done in doctors' offices. It's done in many types of outpatient centers, and it's certainly done at home. It is often done through the pharmacy, and given these days and things and COVID that we went through, the advent of doing this online and through telehealth services has certainly picked up. And so that's a little bit about what we do. And as I said, for many of us, it's all of the things that I just talked about, and it's also much, much more. And we learn we learn all that we can. It can be very daunting to learn all those things that we need to learn. So guidance from those who are formally taking care of us in hospitals and again, other environments can be a real key to successful outcomes. And again, that's true even outside the hospital.
Thanks, Bob. That was great. My name is Denise Lamara. I'm the director of the Standardized Patient Program in the School of Medicine at Penn. We work with medical students primarily, but we also partner with the health system to provide educational programming for many different groups. So what is a standardized patient, you might wonder? First, I'll just give you a little bit of information about myself. I've been in this role for 17 years. Prior to that, I worked with the National Board of Osteopathic Medical Examiners and the National Board of Medical Examiners for clinical licensure exams involving standardized patients, who are essentially, you could go to the next slide, please, Carolyn. Standardized patients are essentially actors. It's kind of like role play on steroids, because the difference between role play and standardized patient methodology is that, as the name implies, the patients are standardized. So they're highly trained professionals to help people teach and test medical students and other trainees. So like I said, we work with the health system. We do work with the School of Veterinary Medicine and Dental Medicine. We have many, many clients. And one of the interesting things that we started with Carolyn years ago is having standardized patients work for the Teach Back class. What it offers you is a safe space for clinical practice. So rather than learning when they're for the first time trying to apply some new methodology or new framework, instead of practicing with a real patient for patient safety reasons and for student safety reasons, and we're trying to create a safe environment for everybody, gives you a chance to make mistakes and role play where you can actually call a timeout and say, I didn't like the way I started this conversation. Can I do it again? Now, when you role play with your peers in any kind of training you've had, you might go easy on somebody. You have a lot of history there. The person's not trained according to standards of practice. So standardized patients level that playing field, and they also give faculty control over the content and complexity of cases. So we can make sure that every single student who is trying to learn anything, whether it's educating a patient about managing their diabetes or dealing with a person who might have COPD, they get the same patient with the same backstory and the same symptoms and all of the same standardized backstory. The other thing that standardized patients do is we will give feedback from the patient or family member's perspective. And you're going to be seeing this in a demo in just a few minutes, but we wanted to just explain that. Next slide, please. So when we're building a case around health literacy, there are a couple of things that we need to think about. One is you're really creating a situation where SPs can portray a case in an authentic way, but also adhering to certain parameters so that they align with the goals of the curriculum. So SPs will know what the learning objectives are. They'll be looking for behaviors that model the reach to teach framework points, for example. It's a loose script for the SPs because they know the story, but we can't script what the learners might say. So SPs are trained to understand it, the gestalt of the entire interaction. And maybe they'll, raise the stakes, we say, so they'll introduce new challenges. Maybe a trainee is doing a really great job and we need to make it a little bit more difficult, or maybe they're struggling. So the SPs will calibrate in real time. The other thing is that we'll create in health literacy cases a glossary of terms. If I asked all of you to think of a patient right now who has low health literacy, I guarantee that we're going to get a wide variety of opinions of what that looks like. So what standardized patients help us do is reduce the chances for variability. So we'll say, these are phrases you've heard. These are phrases you've never heard of. These are things that you understand. And again, we're just standardizing that experience so we can make sure everybody gets the same kind of training. Next slide, please. As you all know, health literacy does not equal intelligence. So we have to remind, when we're training our SPs, we remind them that they have to, put on a different hat. They have to portray somebody who's maybe not at their level of health literacy or self-advocacy. In our program, we have about 200 SPs. Many of them are professional actors, but many of them are not. And we always say, as Bob was saying, we say not about us, without us. So it's important for us to involve people who have different life experiences or backgrounds, or maybe are gender diverse, or who have had experience with diabetes or whatever their health condition is, because we want to create that authenticity, and we also want to be respectful and make sure that patients are presented accurately. Okay, next slide. As we transition to the simulation, I'll just say that when you think about doing something like this at your own institution, understand it's a very dynamic process. You would work with SP educators as well as the facilitators, so the course directors like Carolyn, and the facilitator Haley is going to demonstrate that as part of our simulation. We are constantly kind of seeing, oh, is this working? Do we need to make some changes? Maybe the guidelines on treatment have changed, so we want to make some adjustments. So it is a continuous process. If you want to go to the next slide, we'll talk about the simulation. I'm going to introduce it. Again, this is just for demonstration purposes. Carolyn is going to be playing the part of a trainee, so a nurse who is learning the teach back method and has learned it in the first half of the day and now gets to do some hands-on practice. We've asked Bob to demonstrate the patient, the SP in this scenario. It's going to be a little meta because you're going to hear something like timeout, but that's still part of the simulation. What Haley is going to demonstrate is the role of the facilitator and how we kind of unpack things. So when you hear timeout, Bob will disengage, there will be some conversation. You'll see how this is a human tool that you can use to try something over again, try something new. And then afterwards, Haley will solicit feedback from the SP. So with that, I'm going to mute myself and feel free to throw questions into chat and we'll get to everything.
And just to add on to what Denise has said, well, Haley hops back on here with us. Although Bob and I are going to start out. So with this situation, so as I said to you, we did the didactic in the morning, then we had the patients tell their story, then we come back in the afternoon with the standardized patients and the simulation. One of the first things we do is someone explains how the simulation will work, just like Denise had done, although they do a little bit more. We're giving you a short version of this class. They do a little bit more in depth so they know what to explain and what to understand and everything. And then I actually do usually a demo with one of our standardized patients. And then all the facilitators who are involved in the afternoon, one of them acts as a facilitator, and then the rest of them act as observers. So when we do this simulation, it's not it is one-on-one, but in a group setting. So what happens in the group setting is there is the person who's participating in the program, they work with the standardized patient. Then there is a facilitator, and these are individuals that we train within the health system, and they can come from a variety of backgrounds. Some are healthcare professionals, like we have somebody who's a dietitian, we have some people who are nurses. Haley is a patient education specialist with a background in adult education and health communication. So we have a variety of people who work as facilitators. And then the rest of the group of participants sit there and are observers, and they're actually given a sheet using the reach to teach, and they observe their colleague teaching the patient so that they can provide supportive, encouraging, constructive feedback that we all learn through each other through this process. So that's what we do first, to start out with that. And then we break up into our rooms. We go to all different rooms, into our groups, to all different rooms. And we do this virtually as well as in person. And then we begin the simulation. So at this point, Haley, are you good to go? Bob, you good to go if we start the simulation?
Yep.
All right. Hi, Bob. It's nice to see you back in the office. How are you today?
I'm good, Carolyn. How are you?
I'm good. Thank you for asking. So the last time we met, we decided we would start talking about diet with your diabetes. Is that still okay with you today?
Yes.
Okay. Why don't we start in the morning? Let's start talking about what do you eat, in the first part of your day. Is that okay?
Yeah, that's fine. For the most part, I generally don't even really eat breakfast. I eat typically later in the morning, but often I love to eat bagels. I'm genetically and religiously disposed to being a bagel lover. So I do that, and sometimes very rarely these days do I have cereal, but once in a while, and yogurt and that sort of thing is very, very rare.
Okay. All right. So it sounds like you really like your bagels.
Oh, yeah.
Okay. So one thing I want to talk about with bagels is they're a higher glycemic index type of food, which
Hey,
means
Carolyn,
oh,
this is
hey,
Haley.
Kelly.
Hey, facilitator. Here, I just have a couple questions. I'm going to call a quick timeout. I wanted to hear a little bit more about that term you just used, high glycemic index.
Oh, yeah. Yeah, it's a term I use a lot in practice.
Yep.
I can see why you're a little concerned. Might be a little bit higher level.
Yeah, I just encourage you when we time back in to maybe take a different approach to that and make sure we're explaining it to Bob in a way that he's going to definitely understand.
Sounds good.
Perfect. We'll time back in.
Great. I'll work on that. Okay. Time back in. So Bob, yeah, I mentioned that bigger word, but let me explain a little bit more. So bagels are a food that have you heard of the term carbohydrate?
Yes.
Yes. Okay. So you're familiar with carbohydrates. So bagels have a lot of carbohydrates in them, which means when you eat a bagel, it turns into a lot of sugar, whether it's a sweet bagel or a savory bagel. It's just what it's made out of is that energy source has a lot of carbohydrates and a lot of sugar. So as you talk about your diet with the bagels, I do get a little concerned about that. So how strongly do you feel about eating bagels?
Oh, listen, it's a, I'm an old Jewish guy and we eat bagels. I've been doing it since I was a baby. So there's almost no way I'm going to give them up. Okay.
All right. I need to call a timeout. Haley, I don't, he's really stuck on the bagels and they're just so high and sugar. I'm not sure which direction to go. Have any ideas?
I can see your mind spinning and you're busy thinking of ideas and you're busy thinking of recommendations. How about we try pumping that back to Bob and asking if he has any ideas instead of trying to formulate them on our own?
Okay, so maybe I can do a little combination of maybe one or two suggestions and then kind of engage Bob.
Yeah, see if Bob has something he can build on from those suggestions.
Okay. All right, thanks, Haley. Let me time back in again with Bob. Hey, Bob. So yeah, those bagels are really important to you. And so I'm trying to figure out how do we take something that's really important to you, that's higher in sugar with your diabetes and get it to work for you, because I don't want you to have to give up bagels. So I was kind of thinking about this a little bit. What do you think about like half a bagel or one of those bagel thins?
Well, a half a bagel, I guess could work. Those bagel thins, I'd rather eat cardboard, to be honest.
Just not one of your favorites, huh?
I've tried them and they really are terrible.
Okay. Well, at this point, what do you think might work? I mean, you sound like half a bagel, but you don't sound, to be honest, too thrilled. What do you think might work for you? What ideas do you have?
Obviously I could try eating maybe one less a week or something like that. But another thought that I just had is maybe before I put the bagel in the toaster, I could cut it in half and maybe scoop out the bready part of the bagel and just kind of leave the shell and toss the bready part and maybe for the birds outside or whatever, and maybe just do something like that.
It's a great idea, Bob. Glad you thought. Matter of fact, I might take you up on that idea since I'm pre-diabetic. So, okay, good. Well, it sounds like you're working on some solutions that you'll be able to keep bagels, but at the same time manage your blood sugar. That's excellent. So just to kind of make sure that we've wrapped everything up here and we've looked at all options. And I want to make sure I've explained everything clearly. Can you kind of go over what your options are for the bagels so that you keep the number of carbohydrates down that you think you might be willing to do?
Yeah, I guess I could eat less of them. I could eat only a half, and or I can eat a whole one, but just take as I said before, take all the bready stuff out. That just might work.
Okay. That sounds great. Sounds like you have a plan when you think of breakfast of a way that you can manage your carbohydrate intake to keep your blood sugar down. We are getting to the end of the appointment here. So you don't have any more questions. We can just wrap this up.
Yeah, sure. No more questions.
Yeah, that would be great because we can schedule your next appointment and then, I'll follow up and we'll talk about lunch the next time. How's that sound?
Okay.
Okay. All right, Bob. Well, thank you so much for coming in and I'll see you in a few weeks.
Thank you.
Okay, that sums up our simulation. Bob, our standardized patient, let's start with you.
Yep.
Any thoughts or tell us a little bit about your experience?
Well, I thought in general, I thought it went pretty well. I'd say that for me to have there's a positive takeaway and effect and maybe a constructive one as well. On the positive side, we talked about an issue that's important to me, or in this case, a bagel. And I think we came up with we had a good interaction and came up with a good solution. I like the idea of being involved in those decisions. I think that's important to me as a patient, and I would argue that would be true for others as well. So I thought that was good. On the not so good side, I felt a little bit rushed at the end. I felt like Carolyn was sort of had her 1 foot out the door, and so that's my only constructive comment.
Haley, if you don't mind, I'm going to interject for just a second. Usually the standardized patient, they're really working with the participant and give that feedback like directly to the participant, kind of one-on-one. And the other thing too is often the standardized patient will kind of start out by asking the participant, well, how was that for you? And like in my situation, I would have said, well, I said that bigger word that I shouldn't have said. But on the whole, I thought I got through the reach to teach and did okay. And then the standardized patient would give more feedback. So Haley, thanks for letting me interject that.
Yeah, this was sort of the Reader's Digest version of what a full simulation would be. We just wanted to give you a flavor and a brief demonstration. So thank you, Bob. Great job. Thank you, Carolyn. And I'll answer some questions I see coming through in the chat. And that's all.
Haley, do you want to go ahead as the facilitator?
Yep, I would typically, as a facilitator, provide feedback for the sake of time. I'm going to kind of wrap that into my slides that are going to come in the next section. But typically, I would kind of recap and bring all the pieces together and provide 1 or 2 pieces of constructive or positive feedback. So without else to do, my name's Haley Fuller. I am going to discuss the facilitator's role, which is the role that many of you may be holding should your organization decide to take on this course. I am our supervisor of patient education and engagement at one of the Penn facilities located in Lancaster, Pennsylvania. Next slide. So the facilitator's role, you got to see, as Denise said, the Reader's Digest version of what the facilitator typically does. But the facilitator holds many roles and wears many hats throughout the course and throughout the simulation. So we're doing everything from supporting participants, we're answering questions both before the simulation starts, during the simulation, and then, as I said, prompting the standardized patient to support feedback at the end. We are organizing the simulation scenarios, which I'll talk a little bit more about, and we're guiding participants and serving as the timekeeper. Next slide. So supporting participants, as Carolyn discussed, our participants come from a wide array of backgrounds as well as our facilitators. So for some of them, this is a new or different experience. Some of them have anxiety or less than positive experiences from other simulation experiences, not with our standardized patients, but potentially in a professional training setting, like a nursing school. So we want our participants to feel psychologically safe, but we also understand that this is a slightly anxious experience. So I like to say we want them to feel safely anxious, that they're in an environment where they can make mistakes, and that as a team, we will support them in integrating those new skills into their practice and kind of honing them in during the simulation time. Next slide. We're going to answer questions, like I said, with the varied experience comes a lot of different questions. We want to clarify as much as we can before the process or the simulation starts. And we'll also explain that time in and time out process, like Denise mentioned. Sometimes we'll go through a whole day, nobody will call a timeout. Other sessions, we have participants consistently or facilitators calling that time in and time out process to help facilitate the an effective simulation. Next slide. We're going to organize those scenarios. So we have one main background scenario. Currently, that's on diabetes. Within that, we have a few different sub-scenarios that each participant will focus on during their encounter. Diet, medications, so that we're not all focusing on the same content. We are looking at creating a non-clinical scenario because we're starting to have staff that are from financial aid or our call centers or areas that interact with patients and do education, but not in the formal clinical setting. So looking at expanding our scenarios. And we're focusing on this reach to teach, which is what Carolyn discussed earlier, that relating the patient, educating simply, asking and answering questions, checking for understanding, hopefully using TeachBack, and doing whatever they can to help promote health literacy. Next slide. So as I shared, we guide participants and serve as the timekeeper. So on an individual level, where there is the timekeeper, we'll help them during time ins and times out. And we want them to stay in that reach to teach framework. And as a group, we are there to guide the group as they transition and to solicit feedback. Our supporting feedback process, one of the most important parts of a standardized patient program, like Denise mentioned, you don't get this good feedback typically when you're doing a simulation with your colleagues, because it's hard to provide effective and constructive feedback. So this is one of the big pluses of using a standardized patient. As Carolyn mentioned, they typically drive the feedback process, but the facilitator is there to provide guardrails. As I shared, sometimes the facilitator will focus on open-ended questions, they typically will, and some self-reflection for that participant. The other participant will also give feedback. So in this case, that would have, if Carolyn would have had colleagues, and we're encouraging diverse feedback. Sometimes we'll see that people pick one topic and every participant likes to build on that same topic. But we want to give the participant good and effective feedback. So we really try to balance that with both affirmations and constructive feedback, as well as focusing on different aspects of Reach to Teach. Next slide. And that is the role of our facilitator.
So that kind of wraps up our discussion about our demonstration of the simulation and all the different roles that play in the simulation. So one of the things I think that you're here to see from the course is what are our outcomes? Well, we know that we have an increase in knowledge from 70 to at least 85% when we do knowledge tests at the beginning, at the end of the program. As far as the program evaluation, we have scores that range from like 4.4 to 5, and we get comments such as, this course is excellent, this should be a must for every clinician. And then in the HCAPS in particular, I had access to HUP communication scores. That's the hospital where I work. That's the acronym HUP, Hospital University of Pennsylvania. And we probably have the most participants from the Hospital University of Pennsylvania, is our largest facility. And we have right now our nurse communication scores, which really, The course does focus, for those of you who are familiar with HCAHPS, patient satisfaction scores, nurse communication focus on where you treat with respect, where you listen to, and where things explained to you in a manner you can understand. So we actually deal with all of that in this class, besides how to effectively educate. And right now we're sitting at the 90th percentile, and actually have bumped up to the 92nd percentile when you benchmark us across the country. So we do find that we are having positive outcomes related to this class. Here is our faculty that you have just heard from. And at this point in time, we would like to open it up. I know that things have been put in the chat and there have been questions. So I'm going to stop sharing my screen at this point, and we will go to the chat and be able to answer questions. Haley, is there something that you already have prepared for us? Do you want me to go to Q&A or the chat? Q&A?
I will start with our chat. So a question from Kelly Kidd. How do you address the very common, we don't have time, perceptions that often exist in clinical environments?
Actually, that's an excellent question, and it is one of the things that we emphasize all throughout the course. And I probably need to bring that out a little bit more, that we emphasize that. I have a saying that patient education, every moment is a teaching moment. And so when you think about the reach to teach, you relate to the patient, you educate simply, you know, patient has a conversation, you check for you really have multiple times during the day when you encounter a patient. Now, I think ambulatory is even getting squeezed more. They may have less times to be able to do that, but then again, they may be able to focus more. I had the pleasure of being in the hospital over the last few days. I got out last night just in time, but I was in the emergency room. And the reason I'm bringing this up, on Sunday, I'm working with the nurse, and she said, well, tell me about what you do for our organization, blah, 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 because she has not worked directly with me before. And I said what I do. And I said about, you know, nurses complaining they don't have enough time. She goes, I have time. I said, oh, wait, you have time? Let's talk about this a little bit more. And by the way, her name's Shannon Duffy. I told her I was going to use her as an example today. And Shannon said to me, you know, when I'm setting up a medication, I'm setting up paperwork, I'm setting up a procedure I'm going to do, I'm getting the computer started. Those are all moments and opportunity for me to get to know the patient, or at least start engaging on what do they know about a topic. And then being able to do little bits and pieces about what they need to teach. So it was very nice that Shannon provided that example. But I think we all need to think about when are opportunities to do things that support patient education, even though you may not think that they are. Like as a nurse, I used to love giving bed baths because I had uninterrupted time with a patient where I could assess or whatever. So we just have to take advantage of every moment we have, and then depend on our collaborative partners. You may not be their only visit. Who is the diabetes community program that's out there? Who's the home care nurse that's involved in the patient? Trying to use the whole entire healthcare team to support. So Kelly, I hope that helps to answer that question. That's what we've been working with for our staff.
Thank you, Carolyn. We have 2 questions from Corinne in regards to the curriculum. So Carolyn, I'm going to direct these at you. Do we have a formalized handbook that you share with other organizations?
Currently, we do not. We have worked with one outside organization, and they already had a standardized patient program. So I went up and ran the program for the day in collaboration with their standardized program. They did provide their own facilitators for the afternoon also, but we do not have a handbook or guide at this point.
And Denise, I guess that's for a question for you too.
Well, I just put in the chat a list of references, but you can definitely contact me anytime. I didn't mention, but I'm the Vice President of Operations for our global organization on, it's called the Association of SP Educators. And I've presented nationally and internationally on program administration, recruitment, community collaboration, and case development. I'd be happy to, I could talk about this stuff all day long. It's more fun than my day job. So you can contact me anytime. I'm putting my email. But definitely if you work with or near a medical school, contact them and talk about their standardized patient program, because you do not want to reinvent the wheel. And there are standards of practice in doing this, so you want to do it the right way.
And I'll reiterate what Denise said. I'm throwing my email in the chat also. You're always welcome to reach out to me. I just unfortunately don't have a formal booklet written on this. We'll have to give that some thought. Thank you.
Carolyn, another question from Corinne. So you referenced an increase in knowledge from 10 questions. In which area do you see the most growth? Is this health literacy or practical knowledge like comfort with conversation, or something else?
It's more regular knowledge related to the topics that we cover. Like we put the reach to teach in there. That's a couple of the questions. So it's more flat out knowledge about the best way to educate. And we do mix it up. We look at the whole curriculum. There's a health literacy question. So it's a combination. Hopefully that answer. And Corinne, like I said, I'm putting my email in. I'm more than happy to share that.
And our last question that I see as of now is, do you find the full day course to be a barrier for staff? If yes, how do you address it for frontline staff to have the time to make it to these style courses? And Carolyn, I know this is something that COVID, when we first had to transition to virtual, it was a fear of Carolyn and I, because we're like, who's going to come to a day-long course that's virtual? This is going to be horrible. But we actually saw consistent turnout to the point that it was much larger than we had anticipated. And we still get positive feedback from our standardized patients who are able to be agile and provide essentially the same experience, whether they're in person or virtual. So I must say that one way in which we've addressed, even though it's still a full day, but I believe the virtual has allowed more people to attend than whereas before we would have it in person and it would be at a location that may or may not be feasible for people. In regards to the full, I think it's 8 hours, we get 7.25 hour credit. It is a challenge for people. We have groups that say, can you come to our unit and do a compromised or a smaller program? Carolyn and I have both done that to some degree, but I would think Carolyn and I would both agree that it's hard to keep the integrity of the program with the standardized patient. Of course, that's not a piece that we can take to a unit as easily. Keep the integrity of the program and the impact when it is shorter. So Carolyn.
Yeah, and to add what Haley had to say. So the biggest group that's had the barrier with the day-long program has actually been the physicians. They're the ones that have asked, could we read or listen to the didactic stuff ahead of time and then just come for the afternoon? I can't tell you that we've solved the problem for them, and physician participation in this is very limited. They just have difficulty getting off, period. As far as the rest of the staff, most of the staff, if they're taking the day off it doesn't help to go to 4 hours. It doesn't help to shorten anything because groups have done 4 hours, they've done 2 hours, they've done 6 hours. Usually if it's more than like an hour or like an in-service length, 30 minutes, you might as well have the whole day off. It does limit the amount of participants that we can have. And right now we're running 5 classes with 24 openings during the year. It has varied, it has fluctuated how much participation we have. As we all know, some of us are still very much into a staffing shortage. We're beginning to stabilize a little bit at some of our facilities so that some of the staff can get off. But when first of all, during the pandemic, we took off for a while. And then we worked our way back into virtual. And I have to tell you, having an 8-hour class was a hot discussion. Matter of fact, I was kind of put in the fire a little bit going, you don't really want to do this. They didn't want me to do the 8-hour class. I stuck to my guns. There's a whole backstory, but one of the references they had sent me to ended up being a community friend of mine that they said, don't do the 8-hour class. So I actually called my community friend and said, hey, they sent me your article. How do you feel about an 8-hour class? She goes, oh no, you can do an 8-hour class. So I stuck to the guns and went ahead with the 8-hour class. And I've only had maybe 1 or 2 comments that said the day was long. I think people felt pretty good with the day, and it does just kind of fly by as you try to go through the didactic. You listen to the patients, you're into the simulation, you're out the door. So to answer your question, most times if the staff can be spared for a day long, then the day long is appropriate rather than 4 hours, because that's just even harder to deal with. As far as the shortened version, so we've been playing with that a little bit more. So you talk about different groups. We have ambassadors, they call them red coat ambassadors, and they sit throughout our facilities and help guide patients, answer questions, etc. So we've been doing like our long classes with them, kind of giving a scenario, doing teach back, and they are role playing with each other because standardized patients are hard for us to incorporate into something short like that. We've done this. I've done this with our evidence-based practice groups in nursing. We've done it with diabetes, sting care, falls. So we have found ways to do shorter things to at least get some of the core principles out. But one of the things we kind of stick to our guns about is the person has to practice it. There's no point in coming and just talking about it. They really have to practice it and get a little bit of feedback. So we do, and we'll borrow each other. Like Haley came, we did a virtual thing with our diabetes champions, and Haley from Lancaster General hopped on and helped out because I needed facilitators to do it. We gave them the background information at one meeting, and then we went ahead and did that. So that's how we've been doing some of it.
So Carolyn, I want to build on the concept that you mentioned, needing to practice. So our simulation with our standardized patients is an opportunity to practice. But Ricardo has a question for the team in regards to ongoing practice. Do you conduct any follow-up with trainees post-training to assess long-term adoption, perhaps increase self-efficacy?
And Haley, you can probably answer this as well as I can. We're actually looking at doing some revision to the courses now, giving a little bit of a facelift. And we have tried to do that. And we have not been very successful. We don't have enough staff to follow up with every participant. If we have 24 people at a time, you know, that's 24 people to try to follow up with. We do send them out with a tool that they can use with peers or their supervisor. Although I'll be honest, I don't know if it's ever been used. As if I've tried to follow, I tried following up with leadership for a period of time. There's just so much going on in healthcare. It's tough to make this a priority, unfortunately. But they have the worksheet and they can kind of check off whether they're following certain things, and it's all kind of tied to the reach to teach. But this is an area we would like to strengthen. We just have to figure out how to do that effectively with the resources that we have available. Haley, you want to add anything in on that?
Yeah, I think it is a goal. It is on our radar. Staffing is challenging to keep up with this, but I think if we're looking at a sustainable culture change, this is something that we definitely want to explore a little deeper. And if anyone in the group here does a similar presentation and has good advice on how to stay connected with participants, please let us know, because we want to know what impact this is making throughout the organization. We believe it's making an impact given the scores and information we've shared, but if we can speak to specific projects, we know that the benefit that'll provide.
Gina put in the chat here that they do observations. Yep. And, you know, Gina, we talked about this, but we're like, how do you capture a moment when a nurse is teaching a patient that she doesn't know or he doesn't know? Because I'm the Department of Nursing, so I'm focused on that. This is for any discipline. And by the way, we offer PT CE for this. We offer pharmacy CE for this. So we're into a variety. But it's really hard that how do you do something where you observe that nobody knows you're observing? Because you're going to automatically have the Hawthorne effect. And if you're observing, they're obviously going to want to do it that way. Oh, you've asked their patient education council, but they still, we need to talk a little bit more. Please email me. Just because anybody coming to watch somebody teach on the floor would be odd. Like they would be like, who are you? You know, why are you there? So that's the part that we're struggling with at the present time. So you bring up a really good question. Anything else in the chat? Denise, anything that you were responding to that you want to comment on our last couple of minutes? Anything for Bob at all in the patient panel? By the way, I love the patient panel. Yes. They're great. It's great to hear their stories. I think it just adds, the staff just sit there. I think they're just in amazement because once again, they're just not thinking about it from the patient perspective. Mm-hmm.
Yeah, I think you expect a didactic, you expect a simulation, but when you have these patients in front of you, I know the session I attended as a participant, there were tears across the room because it's just so heartwarming, and it takes strategy, it takes science, it takes research, and it puts a face to it. So thank you, Bob, and all of our other patients.
Well, we're closing in. I've gotten the 1-minute warning. So thank you everybody for joining us and letting us share the program. You have a couple of our email addresses. Enjoy the rest of the conference. And we've really enjoyed being with you. Thank you so much.
Thank you for your time, everybody. Enjoy your conference.
Bye all.